My name is Jack Crow. I am an aortic dissection survivor. I'm 5 years stable, and I am an aortic athlete. Um, about a year ago, the European Journal of Preventive Cardiology did the first ever medical journal article about aortic athletes. And it was based on a survey of about 250 of us where we asked questions about what type of aortic disease you had. So we know that 36% are aortic dissection survivors, 46% of people are on watch and wait, about 18% have had an aneurysm that was repaired, no dissection. But we also asked questions about fear of exercise. And really the big aha or takeaway from this survey was that 70% of people, of aortic athletes, so these are active people who filled out the survey, were afraid to exercise either after their diagnosis or after they had an aortic dissection. And that's the bad news. The good news is that once they joined the group and got peer-to-peer support, and once they watched videos like the one we're going to have here tonight, uh, many people modified their exertion level from vigorous to more moderate. So they reduced their exertion level. And they also tended to do, if they were lifting, they weren't doing the Valsalva, they were doing more high reps, lighter weights. And as a result, 68% of those who felt a lot of fear had reduced fear. And that's why today we're going to be talking with Sam Sears, who's a doctor of clinical psychology and a professor at the Departments of Psychology and Cardiological Sciences at East Carolina University. He's a prolific researcher and writer on mental health and cardiovascular and aortic issues, as we're going to hear. And he's credited with creating the first widely used scale on fear in patients shocked with defibrillators. He's published hundreds of articles, scientific journals, and he recently presented at the John Ritter Foundation for Aortic Health conference, I think in Texas, and that's where we first encountered him. So I want you to remember that tonight's conversation is for educational purposes only. And that's because all of us with aortic disease are different. And we need to talk to our own cardiologist about the exercise that's appropriate for us. And in the context of tonight's conversation, the same goes for mental health. If you're experiencing a mental health issue or crisis, I want you to reach out to a mental health professional that's near to you. Reach out to your care providers. Don't stay alone. We're here to support you, but you also need to reach out for the help that you need. So also remember to click like on the video here down below so that AI sends it out into the ethos. And also remember to join Aortic Athletes and Aortic Hope on Facebook. Sam Sears, welcome to Aortic Athletes, man. Good to see you.
Great to see you. Thanks so much, Jack. You guys are an amazing group. I'm excited to be here. Thanks for having me. So I want to bring up my talk and see if I can lead a little bit of discussion here that take us in some new directions and talk a little bit about this idea of fear of exertion that you spoke of. Well, as a psychologist in cardiology for the last 30 plus years, I've seen a lot of cases. I've seen a lot of folks dealing with a range of life-threatening or potentially uncertain kinds of conditions that are scary. And over the last 3 to 4 years, I've zeroed in on aortic patients because I work closely with a young surgeon, Dr. Ben Degner, and a nurse practitioner, Erica Barwick. And the three of us really thought about what do our aortic patients need? And it wasn't long before we said, we got the case of a fearful aorta here, and we've got to figure out how to address that very idea. And it's consistent with a lot of the work I've done in patients with arrhythmias, implantable defibrillators, heart failure. And it starts with this idea of Nice try hard, I'm still here. A little bit of pushback on the threats of life. Understandably, fear is present, but finding a way to push back is really what we're all about. This is where I work in eastern North Carolina. You can see our large medical center. It's the 23rd largest in the country, 1,100 beds. You can see that just beyond the medical center, it goes rural super fast. So much so that when I show this picture, people are kind of amazed, like, where does everyone live? But the vision we have for the Heart Institute and the driving force of my career is to somehow empower patients to be the most confident and reasonably active patients in the world. Which doesn't mean being reckless. It means confidence means knowing what you can and can't do safely, strongly. We really believe this idea of comprehensive care can produce this kind of outcome. And you guys believe that too. You know, aortic athletes is a very impressive group. It stands out in many ways from the other kinds of patient advocacy groups. And it really stands out in part because of the motto, don't quit, adapt. By definition, that means to maintain your behavior, don't quit, and to psychologically adapt, become adaptable and confident in what you've done. So we share a lot of the same ideas. In fact, so much so that I would say, this is my sassy kind of intellectual punch that I throw to cardiologists. I say, hey, there's no such thing as cardiology without psychology. If you think you can practice cardiology without understanding the psyche of your patients, you're kidding yourself. Because if it affects the heart, then it affects the mind. There's no way around it. You can't somehow medicalize the human experience of fear or of a loved one's fear about something that could go wrong. So there really is no such thing as cardiology without psychology. And we have to get to the fundamental psychologic principle that I seek for my patients in my work, and that is seeking cardiac safety. Can we go about our business on the beam of life and recognize that you can feel safe even in the context of threat? Of course, this is the skyscraper builders of New York City in the early 1900s. There obviously was no government agency protecting the workers here, unfortunately. But nonetheless, look at what these guys are doing. This famous picture shows the tolerance of threat, the tolerance of fear, and going about your business in some ways anyway. I think it's an impressive one for those reasons. And it's very much what I believe in heart patients have to do in some ways. Again, not reckless, not without safety nets, quite the opposite, with safety nets, but recognizing that you can tolerate many of the things around you. So psychological distress is part of the picture, though, for about a third of our patients with aortic, various levels of care with aortic disease. About a third of our patients, according to this a little bit older study, 32% being reporting enough depression and anxiety. And it was most likely in the most non-active patients, meaning that patients that had disengaged or pulled back from life, they were much more likely to be distressed. It's a little bit of a chicken and egg, right? Distressed people pull back and people who pull back get distressed. But collectively, it highlights that a third of the patients dealing with aortic disease have a comorbidity, have a co-occurring condition, and most clinics don't have a way to address it. It's just simply left to its own, which doesn't make a lot of sense. So about 3 years ago now, we initiated a large research program about our patients at East Carolina, highlighting the reality of our patients and highlighting that what could we learn from the different groups of aortic patients, and then specifically looking at depression and anxiety. And one of the things I'll highlight here as it gets bigger is that the anxiety rates in our study were closer to 46% on the surgical and 40% on the surveillance group. You'll note the rates of depression being 30% in the surgical group, and only 15% on the surveillance. That is a significant difference. There was not a significant difference here, but this is a high rate. So, of course, these groups commingle, but it shows you that as many as a third to 46% of patients are dealing with depression and anxiety in the aortic clinic. And most recently, within a month or so ago, we published this study looking at 67 patients with aortic aneurysm. And we asked, well, maybe the patients that are stressed are simply the ones in the worst shape. And the answer to that is false. No. Objective risk, it did not predict perceived risk. Again, indicating that patients' psychology, how patients understand what's wrong, may be more important than actually understanding how much risk they face. And we've done more work with these groups where we looked at quality of life days using the CDC measure of quality of life. And in this measure, you ask patients, how many days in the last 30 days did you have poor physical health? How many days in the past 30 did you have poor mental health? And then how many days were significantly impacted by by poor physical or mental health per month? And so what you see here is that you start saying, hey, I mean, 1 out of every 3 or 4 days, people are reporting in the surgical group problems. Now, over here in the surveillance group, it looks a little bit better. This is kind of a surprise. Some people believed, and there is some data to support the surgical group sort of bouncing back after their Band-Aid over the heart here. But our data showed the surveillance patients were actually doing better. And in particular, what was going on? They highlighted symptoms, heightened attention to cardiac symptoms, greater fear of exertion, greater fear of recurrence, heightened physical burden of disease, and heightened mental health disease. Now, one of the things I want to highlight here is my research across cardiology has pushed us to move beyond simply this number is depressed and this number is anxious. Instead, I'm much more interested in this kind of thing. How many, let's deal with actual things that probably 100% of patients deal with. Well, according to Jack's work, the study that Jack was a part of, I mean, it's probably 70% were fear of exertion. So why would I chase down the 20% or 30% when high numbers have fear of exertion? And that's where part of our research is headed now. Now, the psychology of exertion is pretty interesting, and it's definitely related to the aortic athlete mission here. Two terms have come about in our literature to study this. The first is exercise sensitivity. And here it's the fear of bodily sensations. So this is really the fear of palpitations, the fear of pressure, the fear of pain in the chest. We have less data about exercise sensitivity, but we have much more data on this word kinesiophobia, which is basically just excessive or irrational fear of physical activity or exercise due to fear of injury or re-injury. Now, the reason the word kinesiophobia sort of hangs around with us is this was originally used to describe people's fear of falling during movement, mostly from other kinds of conditions like stroke. What's happened more recently is kinesiophobia has taken on a cardiac-centric view as well. And so I'm still not in love with the term kinesiophobia. I mean, I think fear of exertion gets at both a little bit more. But for the purpose of this discussion, we need to be able to sort of interchange these words because they help us understand some things. So I wanted to highlight a little bit of literature about this. So this is a study we have under review. It should be accepted any day now. 106 aortic patients. And what we showed was, well, what percentage of aortic patients are doing anything in this rural sample? And you can see that 62% of the surveillance patients and 76% of the surgery patients reported no activity, none. Now, this was self-reported. We're doing some work around accelerometry, objective measures, things like watches and devices and things that can measure movement. But only 7% of patients actually met the guidelines. And we implicate the fear of exertion because when you go back and look, the most common reported, the median was 4 out of a 5 scale. So fear of exertion was definitely in play here. It's kind of what Jack said in the introduction, where returning to activity is kind of avoided. And if you avoid it, maybe that's a way of trying to manage anxiety in some way. But our data suggests that really won't work in the long run. It might work in the short run, but it won't work in the long run. What about fear of exertion in other patients, since we're so interested in this idea? The data suggests that in a review of studies, it's between 39 and 82% of surgery patients across cardiovascular surgery, and aortic patients kind of fit right in there at 42% with other people's studies, not ours, but other people's studies. We come in pretty close to that, though. More recently, there's been some data looking in Chinese patients, aortic dissection survivors. So these are patients who had the true dissection, sampled 1 month after surgery. 73% reported kinesiophobia using the measure of kinesiophobia. And kinesiophobia was linked to being older, to having a type A dissection, no spouse. Note that, no spouse, lower education, and more invasive surgery. That wasn't totally clear what invasive surgery meant here, given they were all dissection survivors. I think it had to do with something else happened in the operative environment. Family support and adaptive coping reduce the effects of kinesiophobia. So what all this means is now we move beyond simply the occurrence of kinesiophobia. We start thinking about, well, what are the factors that lead to it? This study is important. Generalizing studies from China to a U.S. sample has some tediousness to it, but it certainly gives us a direction to look in American aortic patients about no spouse, namely, and the lack of family support being a critical element in development of kinesiophobia. A couple other things then about, well, what about fear of exertion? So what, Dr. Sears? I don't care. I don't want to exert myself. I don't really like to exercise. Leave me alone. Well, the problem is that when we have fear of exertion or fear of movement, we avoid activity, but that leads us to get weaker. And everyday tasks feel harder, and then we get more fear. So this fear avoidance loop sort of curls back around. So it's not so much that you have to become an aortic athlete, but moving, continuing some degree of movement is important. And I think the other thing it highlights to me that Jack mentioned was that you know you don't have to become an aortic athlete, but at least become an aortic mover. You got to move. Uh, it doesn't sound as crisp of a title. Aortic athletes, just like that, man, we should get shirts, like Jack has. But aortic mover, maybe we could come up with something else, I don't know. You know, I'll come up with something, but moving patients, me being able to move really matters. So fear of exertion has implications. Now, we also now have the first, in my view, sturdy study to look at exercise. So I think you've had Dr. Prakash on the show before.
Yeah.
Dr. Prakash in Houston. He had a grant from the Ritter Foundation that looked at 99 patients, status post type A or B repair, and he randomized these 99 patients to either an exercise arm or a usual care arm. Usual care being a course education and counseling, exercise being moderate intensity, home-based, guided exercise program. And this study was published, is published, I believe, in August, so it'll be out next month. It's in preprint now, and it shows that moderate intensity was feasible and not associated with any new problems. It was not dangerous to engage in moderate intensity activity. This is a very, very important study, and I think it stands out in the literature as perhaps the most important study for us in our conversations tonight. Dr. Prakash is an expert in this. He can do a better job of discussing some of the limitations of the study. But obviously, we can't make too much of any study that has 100 patients. We really have to continue to study this, be careful, and create individualized programs. But I think this is a reassuring message about exercise can be safe. And this has to do with this idea of comments and worries about exertion, fear of exertion. And this connection between activity and psychological well-being is robustly seen across patients with more significant heart-related problems, meaning that patients with rhythmic disorders, heart failure, all of these patient groups with a more significant cardiac condition that's being followed can come up with all these kinds of worries about how they're doing. Can I handle it? Every twinge feels like something's wrong. My family gets nervous when I do anything, overprotection. I don't trust my body. All of these kinds of concerns go into the kinds of things that come to your group. Of course, this is the article that Jack mentioned in the introduction, where very nicely done, very impressive paper. I really hats off to you for this work. 224 patients from the group, from the patient support group, and reduced fear being one of the benefits of participating. But we shouldn't think about this magically. We should really think about why. Why does that happen? Why would someone feel better because they participated in aortic athletes? And I think it has to do with the emotional validation, good information, uh, interpersonal support, and feeling connected, feeling like you're not just out there on your own. Very few aortic patients know anybody that has aortic disease, so you're often on your own. But connecting online and in a truly modern way was quite helpful. And this is impressive that we have this data. Now, when you think about if any of you were to come see me clinically and you say, well, I'm here to see Dr. Sears, fix me. Well, the place we would start is looking at how cardiac events change these three models. This is a study, this is a model we've been studying for almost 25, 30 years now, where cardiac events change people's thinking. Things like, if this ever happens again, I'm not going to make it. They cite scary statistics and they say they think about worst case scenarios. That's catastrophic thinking. They disengage so that 70% of people who say, I'm not going to do anything anymore, they're going to quit and not adapt. Avoidance behavior is a key factor. And then finally, as you heard in one of those quotes, every twinge becomes somatic hypervigilance, which means very much attending to your body and listening to your body. Listening is what we call that, where you're spending a lot of time listening to your body, either with blood pressure or smart watches or whatever, but spending a lot of time. These three levers create the fear and the reduction in quality of life that we are trying to manage. So people go, fix me down here, but usually we have to fix you up here to fix you down here. So hypervigilance is this idea of body listening I mentioned, and this is a good example of just somebody who's taken tons and tons of blood pressures, constantly taking blood pressures. I had a guy once take blood pressures during a movie, and he was sitting down there on the lights in the aisle writing down his blood pressure, and it's like, hey man, you don't need to take your blood pressure, enjoy the movie. Or avoidance, where you constantly live on the sidelines of your own life. And that can be psychologically challenging when we just disengage. When you disengage, you might protect, but you also don't get anything good either. Or catastrophizing. This is the idea of jumping to the worst conclusion. It happens in both men and women. And we think that changes by trying to focus more on the survivorship idea. So I have just a couple more minutes of comments here. I wanted to talk a little bit about what we know about changing fear, since we've shared with you that fear of exertion is part of the picture. It is something that we're familiar with across all heart patients. So people say, help me stamp out anxiety. Well, one of the reasons anxiety is so difficult to manage for many patients is A, they don't want to confront it, and B, what happens next is when they confront it, they feel worse, convincing them they shouldn't have confronted it. But instead, the reversing anxiety cycle means confronting it and feeling a little bit worse in the short term, engaging in coping strategies like self-care and getting support from others and distraction and faith and family and all the good things that bring us through our lives, in order to increase confidence of managing this, and anxiety then diminishes because you have made it through this cycle. So when you think about this exercise concept that we've shared with you tonight, there are a number of quick points that I want to point out. I mean, first, the fear of moving is normal. It's so common that with anywhere from 30 to 80% of patients feeling fearful of moving, it's normal and expected. It's treatable when we, in fact, remind ourselves movement is medicine in the right dose. So, consulting with your medical team, cardiac rehab, physical therapists about building an exercise program that is well suited to you. Skip the max effort, instead of going all out. I mean, we got a long game to play here. Cardiac rehab builds trust, small steps beat big leaps, and bring people with you. Finally, as I mentioned, there's no cardiology without psychology. So what do I say from a psychology standpoint? Well, I say first is that identify quality of life to you. What does quality of life mean to you? And what are the values that you have? So blending values and quality of life often leads to the best results. Research into behavioral re-engagement suggests that when we can identify values, things we love in our life, and pursue those, quality of life is in that mix. Rather than try to find the mythical land of quality of life, usually what we have to do is move through the land of values and the tolerance of some distress to get there. Secondly, behavior matters. Getting into activities of fun and activities that help you feel close to other people you love and activities of awe. When you get a chance to see something special, awe like the redwood forest, or awe like a great cup of coffee, or awe like seeing somebody in your family do something amazing, or activities that bring you peace. These activities are the psychology of cardiology, reminding yourself you have to re-engage to benefit. Approach anxiety and avoid avoidance, of course. Doing beats thinking, treat fear. You got to do some stuff. We can't fix your anxiety by simply thinking about it. We actually have to do things to manage it. And finally, bring a buddy. Anxiety gets worse before it gets better, so you play a long game to win. So I love taking care and being a part of heart patients' lives. I think aortic patients have a very unique set of challenges, but I'm also very clear in my thoughts that the adversities of cardiac problems can actually bring out new priorities and bring out the best in you. I actually believe that psychologically, heart disease of any sort can actually create a better you in many ways. As Pollyannish as that might sound, I believe that the adversities actually become part of the strengths that take you forward. And so I'll end with this idea again. There's no cardiology without psychology. Living with aortic disease means that you got to understand what makes yourself tick, manage the fears of exertion, and identify and pursue quality of life. Thanks very much.
Holy cow, Sam. I don't know where to start.
All right.
That is what a tour de force. There's so many angles to go on this.
Good.
One, well, should we start dumping on the cardiology profession immediately for their failure to address any of this, or should we let's put that aside for later. We'll get to that. But first, when people get diagnosed with, you mentioned ambiguity, when people get diagnosed with aortic disease, it's obviously, it can be a shock,
Yeah.
my life is over, all this kind of stuff. But there actually is a period, if people are on watch and wait, where they don't know if they're stable. In other words, you might have an aneurysm of 4.3 or 4.7 or whatever, and they've got to wait 6 or 12 months till their next CT
Yeah.
to see, am I stable, or is this like growing quickly and we're going to head right into surgery? And so how can we as aortic athletes better accompany the newly diagnosed people who are just in the freak out moment and trying to take all this in, and they have legitimate ambiguity about what the outcome's going to be?
I wish I had some magic beans here. This is actually why this is so challenging. The ambiguity, in my view, is our key area of focus right now. What that means is when we aren't sure how to feel, that's emotional ambiguity, or we're not sure what to think, which is cognitive ambiguity, um, distress can follow. Ambiguity can equal anxiety. Let me say that again. Ambiguity can equal anxiety. And so I don't think false reassurance is very good. I think what we need to do is say, uh, meet these people where they are. I understand that you don't know how to feel. I understand that you feel like you're at a crossways here in terms of your life. And I think validate those feelings. Validate that it's easy to let it worry, but you are here now. Risk, medical risk is this new psychological challenge where we can tell you you have a risk for some future problem, and we weren't able to do that. I mean, even you come up with some genetic marker and we say, well, we may have to deal with this someday. But the truth is, none of us are guaranteed every day. We're not guaranteed anything. So ambiguity becomes part of that. Now, the other thing we've tried to do is rather than get into the philosophy of ambiguity, which I kind of just did, we've also tried to look at what happens to people who are uncertain what's wrong with them. So we've looked at a couple of different studies now. We just published a study with 3,500 patients that had what's called an insertable loop recorder, which is a small device that we insert in the chest to monitor the heart. And we're looking, it's when we don't know what's wrong with someone. We think, oh, they're having palpitations or fainting spells every now and then, but we can never catch it on a wearable. So we put this device in. And this device happens to have an accelerometer. And in this group of 3,000 patients, we showed that of all the patients in a cardiac clinic, those with much more severe and known conditions, those that had unknown conditions were by far the least active, meaning that the data suggested they were active about 2 hours and 10 minutes a day. The device detected movement. So this is a fancy Fitbit in a way, and it shows that even compared to patients with known much more severe conditions, they're up in the 3-hour range. These patients were down in the 2s. So we don't have easy fixes for ambiguity because, in my view, too many times people reassure with false hope. I think what the reassurances are these. What have you done to reduce ambiguity? 1, I've gone to a good doctor. 2, I've gone to CAT scans. 3, I've taken my medicines. 4, I'm in learning as much as I can. 5, I've talked about my feelings. 6, I've talked to my family. 7, I've restored as much behavior as I can do based on the doctor's advice. That's 7 things you did. Is it really that ambiguous? I mean, you're making control where control can be done authentically. What I don't want is nonsense. What I don't want is fake hope. I don't think that's good for anyone. I do think that directing your efforts in a deliberate way and seeking deliberate reassurance from the key people that have that information is sound psychologically.
All right, so let's look at a slightly different angle on ambiguity. When people join the group, they want clarity. They want to know, can I power lift? or and we'll get to the dumping on the cardiologist, but my doctor said I can't lift more than 50 pounds. And is that the right amount of pounds I should lift? And the question I want to ask is, well, is your blood pressure 120 over 80 at rest?
Yeah, right.
How do you have chronicity? How long have you been stable? So if you were just diagnosed yesterday with a 5.0, I might think about it differently than if you've been at 4.5 for 15 years. This is, and then there's also you mentioned briefly genetics. Apparently, the guess is somewhere between 10 and 30% of us have genetic. I have genetic, and I know that, even though I don't know what the gene is, because I have 5 out of 6 siblings who all have aortic disease. So I'm clearly familial, but and then there's most people are not genetic. It's a spontaneous change. The data Dr. Alan Braverman, who works a lot with Dr. Prakash, and they're both close friends of ours in aortic athletes, did a study in 2022 about post-repair non-familial bicuspid aneurysm. So kind of a subset, kind of a really good, the easy cases, let's say.
Yeah.
And he had, I don't know, of 80 people, did like 300 endurance events, and there were no adverse events that occurred with that group. So it when people want to know what exercise can I do that's safe, the answer, unfortunately, is always it depends, and it's going to be individual. Whether you're familiar, if you have Marfan, it's going to be one thing, and
that's right. No, it is the case, and I think that I think as doctors, we're always wanting to say what we do know and we don't know. We don't know everything we need to know. That's why research is so important. Research is a hassle to participate in, but we need it. We can't. That's the only way we can learn. Uh, Research in this country remains an essential area for development. We dedicate our lives to trying to understand the problems that our patients face. And so sometimes the ambiguity persists because we simply don't know. But what we do is build safety nets. I don't know uh, the variable of unknown significance in the genetics or the rate of growth of an aneurysm. We simply don't know. But what we can do is build a safety net and target the things we can do, focus more on what we can do rather than this every unknown. We live in ambiguity. The edge of medical technology is right here. We don't know everything we need to know, but we're getting better. We're getting better fast.
Yeah, and so let's talk about joint decision making and risk.
Yeah.
I like the way you discussed. The fact is, the vast majority of people in America generally are sedentary.
Right.
Don't
It's around
exercise
70.
much. And the same is true for people who have been diagnosed with aortic disease. I always call us, we're a subgroup of a subgroup of a subgroup, you know. But and we have on the other hand, we have some aortic athletes post dissection want to run their first marathon that they've ever run, and maybe want to take on more risk than they really should. How do we get our care teams to allow us to have the appropriate role in joint decision making that we and patients should have?
Well, this is a new game for the old doctors. For many years, and as recently as maybe 10 years ago, there was the role of prohibition. I mean, basically, the role of cardiologists was to say, you can't do that anymore, period. I told you so. That's turned around, of course, now, and shared decision making has replaced it. So I think the way you go about shared decision making is to talk about what the goals are. What are your goals? I mean, is the goal some sort of physical activity goal? Is the goal long life, no matter what? I mean, I don't think it has to be some golden goal. I think these are the parts of the conversations. It's important to me to be able to travel, for example. It's important for me to be able to play golf. It's important for me to be able to ride my bike distances, whatever the behavioral goals are, and to sort of check those out as is there any greater risk for me doing that versus this? And I think those are conversations, the more precision you can put into it, the better. Now, as you know, we don't have data on every behavior. What we do is we have data on things that have to do with pressure and things that are plausible, meaning that it's plausible that that changes in certain kinds of activities would be harder on an aortic aneurysm than others. It's plausible, and we have some data, usually animal studies, that would tell us that. So again, I think shared decision making does occur with some ambiguity, but it should occur with a shared value set. What you love. I always say, what do you love? I say that all the time in clinic. What do you love? And they go, I don't know, that's a weird question. I say, well, but what do you love to do? Who do you love to do it with? How you like to do it? Hopefully it doesn't get into too much where that might be leading, but usually I'm teasing because it's usually about, I love being in the Upper Peninsula of Michigan. I love being able to go to the beaches of Florida, or come to North Carolina, or whatever it is people like to do, and and to try to articulate that. And many things are safe and reasonable. And even when there's some risk involved, you can go forward with shared decision making should empower you with knowledge about the relative safety of this versus that.
And that's where there's a dichotomy between people who see a lot of aortic patients,
Hmm.
and particularly aortic athletes, versus a lot of cardiologists, the bulk of cardiologists who don't see a lot of us.
Yeah, right.
And, I mean, I've had cardiologists say, look, I'm trying to get my patients to walk. Hey, how about we walk 5 minutes?
Yes,
How about we
yes,
stop smoking?
yes.
you know, and the conversations with us are more about, I ride horses, and I want to continue riding horses. Or we have folks who live in the Rockies who enjoy hiking at elevations, and that can raise their blood pressure a little bit, and they need to go slowly and everything. Um, how do we get the how do we get the information out to the cardiac community in general that things are changing, that there's new data, there's new information about mental health, also about things like Dr. Prakash's. I was in the aortic dissection exercise study,
Yeah,
and I still do the exercises 3 times
that's
a week.
cool.
Yeah, 3 years later. But how do we get that? How do we create a system that's able to talk about mental health with our care providers?
Well, you had talked about piling on to cardiology. There, yeah, I don't think we have to pile on. I think that cardiologists play the role that we need them to play, which is the highly technical. Today's cardiology is highly technical. It's highly data. I mean, it's heavy on data interpretation, analytics. It is much more challenging today to be a healthcare provider. And given the ways in which clinic visits have been shortened, the role of psychologic care, the role of how are you doing, not just let me look at your data. I mean, you're not a data machine. You're still a person that thinks and feels. So I think the challenge for cardiology is to bring about more partners. There needs to be more multidisciplinary care in cardiac practices. Why? Because people live longer now. When you just died quickly, you don't worry about coping. But now people live, and cardiology has to, in my view, go beyond I'm a cardiology clinic and probably move towards something like um, a prehab clinic, a post-hab clinic that really focuses on a set of outcomes, not just did the patient die, but more toward did the patient return to the valued activities they wanted. Now, our research has been focused on accelerometry as a way to proxy that, to simply say, great job on the surgery. Patient's alive. Fantastic. Thank you. We need that. But in the future, I think the outcomes for things like cardiac surgery are going to be, did they return to activity and prove it? Because we're going to have data sensors available to us. Smart clothing, for example, that has plenty of sensors in it. We could tell, if you're sweating, if you're moving, how fast you're breathing. The amount of data we're going to have is going to be quite striking because everything could be detected. The number of times I shrug my shoulders could be detected. I mean, the number of times I touch my bald head, that's all detectable now with the right sensors. And I think when we look at outcomes in the future, people getting back to what they used to do is both a physical and a psychological event. And that's why clinics are going to have to become more complicated or more comprehensive. Because if doctors are held to the standard of restore activity, then they got to do more to restore activity than just operate. And we've seen this already. Heart failure doctors, for example, if you get admitted and you're a Medicare patient, you get admitted, over the next 30 days, if you get readmitted, no more dollars are coming to that institution. because they pay it once and they say for the next, that covers us for 30 days. Don't come back. Don't ask for any more money. And I think the future may be we do a cardiac surgery and they say, show me the activity data. Show me that we got our money's worth. And doctors will say, but I'm not in charge of all that. I know, but you're going to have to build a service that is.
It's funny, Medicare pays for my gym.
Yeah, well, that's pretty
It
good.
doesn't
So,
it doesn't track whether I go.
well, and in the future, I think taxpayers or politicians will say, well, I want to know, what did you use the money we gave you or,
Yeah,
gave to the gym?
yeah. All right. Family members are such an important part of the equation.
Yes.
They may have their own issues.
Yes.
You alluded to that. I
Yes.
remember my wife at some point, saying, we're going at the airport and I picked up some luggage bag and she's like, "What are you doing?"
Right.
I ride my bike 60 miles. I mean, come on.
Yeah.
It's okay. I'm breathing through it, and it's
Sure.
not a problem. But so the family members have their own trauma. They can also be an aid in seeing us if we're sliding into depression.
Yes.
And sometimes they can be the cause of anxiety that's maybe going to drive up our blood pressure and not be good for our aortic stability. How do we bring family members into this conversation?
Well, I think one of the ways is to take it on yourself and say, hey, how am I doing? Ask for feedback. Actually begin a conversation about what do you think I've been doing that's working well, and what do you think I need to get better at? I mean, try to get some praise in there too, right? What do you think about what I've been through, and get some perspectives about yourself? And then I think as you get some feedback, you can then say, I've noticed that you've done this or that, and give positive. But I've also noticed you're scared to death if I pick up a bag, and I want to reassure you that I don't want to hurt myself either. We're a team. The goal here is for us to be together for a long time with good quality of life. So I share your desire to protect me, but I want you to share my desire to get back to normal as much as possible too.
And another thing is always have your wife either listen in or be present when you're talking to your cardiologist about your exercise activities, because typically they will say, keep doing whatever you're doing. It's
Yeah, they
working.
will.
It,
They
it,
will. They
it,
will. And then somebody will say, well, can I get up on the roof and blow leaves? And they say, no, because that's an orthopedic problem, not a cardiac. Nobody, at some point, you can't blow leaves anymore on the roof.
that's a hard one. That's a
Yeah,
hard
I
one,
know it
Sam.
is. It's every clinic. I'm always surprised. It's like there are a couple of things I didn't know that people would insist on doing. The first was blowing leaves off the roof. The other thing I didn't know about was how many people arc weld because they have implantable devices, and we don't like arc welding next to the devices. And so I had no idea until we tried to take it away from people that arc welding was essential to the American mindset.
Tall ladders after 65 years old. We'll talk about that later. Aortic athlete Debbie, who is in watch and wait. I want you to hear this. She says, this is a great quote. She said, when I was first diagnosed, I could not talk about my aneurysm diagnosis without crying.
Mhm.
It felt like the rug had been pulled out from underneath me. Why me? I'm healthy. I exercise every day. This is not fair. She adds, now, 5 years later, I accept and I adapt. And what Debbie didn't put in here is I think she is about to set the record for climbing Mount Whitney 42 times or something like that. So since she's been diagnosed, she's adapted. She reduces her, how much she's pushing it when she climbs, but she's just become acclimated. She's had 5 years stable in watch and wait. And just offer that to you as kind of an example of what our people are going through.
Yeah, and I have a couple of reactions to that. I mean, the first is this is an example of what I was saying was these events can crystallize and your priorities. These events can remind you of what matters most. That I call the special knowledge that comes with heart disease. The other thing is that I'm impressed that she could remember the hard times. A lot of times when we go through things, we don't remember how hard it was early on, and her humility about how hard it was early on, while still now you told the rest of the story, which is she's made this dramatic comeback, but she didn't forget where she started. And I think when we see patients who are new to this, they can't see 5 years out. They can't, they, by definition, when we don't believe our future is desirable, we can become depressed or anxious in the present. And that's a broad sweep, meaning that even if we have to be have rose-colored glasses on about the future, there's some evidence that that's an important part of mental health. We really do need to believe the future has good things in it for us.
You,
Hopelessness is strongly associated with bad mental health outcomes.
you know, aortic athletes on our Facebook group there's a thing when people they've been in watch and wait, they go into surgery, and then they post, I'm in day 2. They've got a picture of themselves. Maybe they show their scar,
Yeah.
and now they're in day 4, and day 6 and 7. And somebody just went for a half a mile walk, and people who are in watch and wait will comment and say thank you. I think there's something, and maybe it comes out of COVID, where we just got so isolated and so alone and disconnected from our communities. I see people in our group kind of appreciating the just looking ahead, seeing, oh, you've been stable for a year. Well, I've only known for a week.
I think that is the case. We call that vicarious learning, right? Where
Ah,
we can learn from what other people, we can see what they tried and it worked. And so we learned that maybe we could try that and it could work. And hope is like that, right? The same way that fear can be infused, you can also infuse hope and say, wow, I can't believe you rode your bike so far today. That's quite unusual. And maybe I could do that. So I just really think that what y'all are doing is impressive. You said this earlier. I mean, the strange thing about your group is exactly what that cardiologist told you. Not only do most Americans not get any activity, but it's even worse in cardiac clinics. We don't have the conversation very often about how far can you go. We usually have the conversation, can you get started somewhere?
hmm. Yeah.
So it's neat what you guys do. As I said, I love your motto. I think that's a really important part. I mean, it's impressive. It really is
Uh,
impressive what this whole group does.
all right, Laura, aortic athlete Laura had a dissection and may be facing a second open heart surgery. And she's asking, how can she better mentally prepare for a non-emergency planned open heart surgery after having emergency open heart surgery for a dissection?
Well, there are a couple of things about this. I mean, one of them is that the emergency surgeries, we don't have data on this, but certainly the traumatic elements of that, unexpected, highly intense, can be associated with more of a trauma stress response, not necessarily PTSD, but a trauma stress response. So this is not just a surgery that she's rolling into. She has experience, and I think embracing and understanding, yes, your previous experience is going to come to life here. But rather than say, oh my God, it was terrible, part of it might have been terrible, but you also now have the benefit of wisdom or experience. So I think count the silver linings here. Count the parts that because you've had this experience, you do know more. Because you've had this condition longer, you're aware of it. Because you've had this surgery, you're probably familiar with your doctors and hospital and medicines and post care. And so those are ways in which you can provide increased control in this new situation. As long
Yeah.
as the trauma stress doesn't somehow throw you off course. So this is a depends question a little bit because yes, I think this does help her. The experience helps her, but the help will be hard to see if she had a true trauma reaction from the previous one. Because when we have trauma reactions, we try to avoid things that relate to that. And now we're going to throw her right back into what she's been trying to avoid. So it depends. I don't know how to answer this without knowing well, how traumatic was the first surgery? And so I would be, if I was her taking care of her, I would say, well, let's talk a little bit about the first one. Let's make sense. Let's warehouse all of the thoughts, feelings, and experiences from the first one, make sense of those, and see what we can take from that warehouse into the next situation, and then prepare for the new one.
And there's also some of us, I call this, there's some of us who have been in the frequent flyer club. I've had two, and the odds are at some point I'll probably need another at some point for, and
Yeah.
well, it's just like, oh, okay, let's go. All right, aortic athlete Ann, another one of my favorite aortic athletes because she climbs mountains in the Rockies too. And this is a quote. She said, "When I asked my and this is in the dumping on cardiologists
Oh, okay. This part, yeah.
genre. When I asked my cardiologist, her PA, my surgeon, and his PA if they had any recommendations for therapists to deal with the aneurysm diagnosis and the fear, she said, I was met with a blank stare. She said, they said no one had ever asked that before. How can that be?"
Yeah. Just to stigmatize mental health a little bit more. Hey, you strange bird asking about mental health. No one's ever asked about this. Even though the incidence of depression and anxiety is over 30% in patients like you, no one's ever asked and we've never referred. So, I think this is one of those cases where we've got, and this is exactly my approach. I believe we have to make mental health care cool.
Yeah.
Meaning that, who doesn't want to be mentally stronger? Who doesn't want to be more resilient? Who doesn't want to be able to encounter adversity and demonstrate to yourself and to everyone you love that you have what it takes to go through it? I think that's an amazing gift to give to your family members. I think your mental health is an amazing demonstration that other people who love you can say, oh, here's one more way I admire you. It's like when I watched my wife give birth. I thought this was the most amazing person I've ever seen. I couldn't have done that. I thought her bravery and all that. And I know that that's a common, that's what we as humans, have that capacity um, to encounter adversity and overcome it. So bottom line is, I think we need to challenge reasonable cardiac facilities to develop multidisciplinary referrals or multidisciplinary teams. Further, I believe psychologic care needs to be routine, meaning that always, annually people have the opportunity to say, hey, how's it been going with your condition? What's been working? What hasn't been working? Is there anything you need help with? Is there anything you're avoiding? Is there anything you've cut out of your life that you'd like to have back? Have you enjoyed this? What have you enjoyed in your life? What kinds of selfies have you taken? Where were they? What were you doing? Who was in them? And, that kind of lifestyle check about how you're doing. I think that that's an important element. It's not just a thought. The evidence suggests that when we don't address psychological factors in heart patients, they cost more to take care of, they do worse, they report more symptoms, they take more medicines, they get more surgeries. Now, it's not a massive effect, but it's an effect. It's not like they're untreated, they're still treated, but they have a condition that undermines the value of the uh, medical enterprise.
All right, last question. Um, Mild depression, maybe moderate depression, go for a walk, exercise is a great idea. But some aortic athletes have, more severe mental health issues. Some may have PTSD from something prior in life or from a dissection.
Yeah.
How do we go about finding someone who can help us? Anne said that when she finally found a therapist on her own, their experience was in cancer survivor,
Yes. Yes.
counseling therapy. How do we find people who can help us, particularly people who are experiencing more severe symptoms?
Well, okay, so let's talk about how we find somebody. Number one is certainly ask your medical team who do they typically refer to? And if you get the blank stare the other reporter gave us, then we got to move on. Second thing we can do is actually each of the state psychologic associations have a Find a Psychologist page. All of them do. And you can ask for, and specifically you're looking for, a health psychologist. So I'm a board certified clinical health psychologist, which means that I use clinical psychology in the context of health or medicine. Okay, so it's not surprising that this cancer psychologist was able to help the heart patient because some of the psychologic processes are the same. Not all are the same, but that person's closer to the kind of work that is needed for somebody with a heart condition. Whereas you might have somebody who's a clinical psychologist who's interested in, marital therapy. Perfectly fine, an important part of the discipline, but not what you need when you have an aortic dissection. And so it's not so much that we aren't trained to do a lot of things, but when we're in specialty medical situations, somebody with a health psychology background will be the best. And so that's what you search for. So first is your doctor. Second is the local or state psychologic page. The third is Psychology Today actually has a search feature that goes beyond psychologists. It has both psychiatrists and other kinds of mental health workers on there. And then I think the fourth is word of mouth, and fifth is probably try a few. In some cities, psychologists or therapists will actually interview you for 10 minutes to see if you like them and they think they can help you. But you got to throw yourself out there. It's like a little bit like dating. I mean, you got to put yourself out there, even if you don't know where it's going. You just don't know. But finding somebody that is honest, humble about what you're going through and can learn along with you if they don't know about it, that's certainly okay. Not everybody can know about everything. They just can't. University hospitals tend to have people who are more specialized or doing research in addition to clinical work, like me, where they would be more comfortable in the medical setting.
All right. Well, one bonus question. Where do you want the research to go? Where do you, in other words, if you're the king of the world,
Yeah.
and could direct research in any particular area, where do you think we need to go?
Well, I'm going to talk about the condition in general. I think the simplest place we should go is cardiac rehab. And it should be both approved and that we should study the effects of cardiac rehab, period. I think secondly, we need to study the effects of comprehensive care. If we add the cost of multidisciplinary care to an aortic clinic, does it produce better outcomes? Does it actually produce better, more cost efficient, and improved outcomes? So I think that we have, and then third, there's all kinds of surgical options and medication options and genetic testing that I'm interested in, but certainly the first two are the low-hanging fruit. And we need to have systematic care for aortic patients so that everybody gets the highest quality of care consistently, regardless of where they are. And so that's why the first two are so important. I just don't want to see patients with significant heart disease, including aortic patients, be under cared for. And I believe when we don't include psychology, we don't include the patient experience of disease, we've undercared for them.
Yeah. Well, Dr. Sam Sears, you are a friend of aortic athletes.
Thank you so much.
We are available and willing if you are looking down the road for people to participate in your work. I have a funny feeling we're going to get a great reaction to this video from our group and from the broader aortic community, because we have a lot of, I call them lurkers. We have a lot of lurkers in aortic athletes, people who want to exercise and know they should but haven't started yet. And we want them to go out for a walk tonight after they watch this video. So thank you so much for your work, and thank you for talking to us tonight.
Pleasure to be here. Thanks so much. Great job for all of y'all, all that your group does as well. Thank you.
Thanks. All right. Good night.
Good night.